And from my view, it seems like AAPLOG is trying to get away from the confusion around the word abortion and just be very specific about what methods and what circumstances you're describing. And ACOG seems to want to not be specific at all. They don't want to ever discuss reasons. They don't want to get too specific. They don't want to be too clear with layman's terms or clear language about processes. They want to use very opaque and vague language when describing this.
Welcome to Caring for Both, a curbside consult series by the American Association of Pro-Life Obstetricians and Gynecologists, or AAPLOG. On this podcast, we bring on experts to provide insights to support you as a medical professional in your life-affirming practice and career. I'm your host for today, Dr. Christina Francis, a board-certified OBGYN and also CEO of AAPLOG. Today, I'm so happy to be back with my friend Monica Snyder. Monica is the Executive Director of Secular Pro-Life. If you haven't heard of them, Secular Pro-Life is a nonprofit organization committed to advancing secular arguments against abortion, creating a pro-life space for non-religious people, and building interfaith coalitions of people interested in advancing secular arguments. Secular Pro-Life creates excellent science-based content on their website and on social media, and I would highly recommend them as a resource. I also don't know how Monica gets the content out as quickly as she does. It's something that I aspire to, actually. So this is going to be our third reverse interview with Monica, in which she asks me questions that she's gathered from her followers around the theme of what patients and pro-life advocates want to know about life-affirming medicine. I'm really excited for the topic for this reverse interview, which will be about comparing and contrasting AAPLOG's Glossary of Medical Terms with the pro-abortion American College of Obstetricians and Gynecologists, or ACOG's quote-unquote guide to language and abortion. AAPLOG and ACOG have significantly different approaches, as I think you'll all hear today, to the language that we feel is most appropriate to use as it relates to pregnancy, induced abortion, and related topics. So I think this is going to be really interesting to explore today. And I think we'll highlight the sort of different focuses of these two organizations. So Monica, I'm going to let you take it from here.
Sure. So before I ask you some questions about the differences and the comparisons, I wanted to let the listeners know kind of where ACOG and AAPLOG are at in terms of their glossaries. I was just going to very quickly read to you the terms that ACOG doesn't like and doesn't want people to say, and the terms that AAPLOG doesn't like and prefers people replace, just so you could see kind of their orientations. So for ACOG's Guide to Language and Abortion, here are the terms they don't want people to say anymore. Late-term abortion, chemical abortion, surgical abortion, heartbeat bill, fetal heartbeat, dismemberment ban, abortion provider, baby or unborn child, self-induced abortion, elective abortion, partial birth abortion, womb, or abortion on demand. Those are all things ACOG would like to replace with other phrases or just remove entirely. And then in contrast, AAPLOG, this is most of the list because you guys did have a little bit of crossover when it came to heartbeats and things, but the list that's exclusive to AAPLOG, terms that they would recommend you replace are the word abortion, which we'll talk about in a second, termination of pregnancy, spontaneous abortion, non-viable embryo, threatened abortion, products of conception, medically indicated abortion or therapeutic abortion, lethal or incompatible with life, fertilized egg, abortifacient, conception, failed abortion, abortion, ban or restriction, and there's a few more after that, but those are the ones that I felt like really focused on the patient relationship right away. Mm-hmm. I was reviewing these two documents to prep for this interview, and I was noticing that, from my view, broadly speaking, ACOG seems to be wanting to use the word abortion more often with less qualifiers and also kind of with less description. So, for example, they don't want anyone to say elective abortion, just the word abortion without any explanation. And they don't want people to say surgical abortion, just abortion procedure. Just things get vaguer with theirs. And AAPLOG actually is almost going in the opposite direction, where the recommended phrases you have don't use the word abortion at all. You've extracted the word abortion and just started describing exactly what you mean. And from my view, it seems like AAPLOG is trying to get away from the confusion around the word abortion and just be very specific about what methods and what circumstances you're describing. And ACOG seems to want to not be specific at all. They don't want to ever discuss reasons. They don't want to get too specific. They don't want to be too clear with layman's terms or clear language about processes. They want to use very opaque and vague language when describing this. Do you have experiences, or do your members of AAPLOG have experiences with patients being confused by this? How, when you developed this, was part of it patient clarity?
Yeah, absolutely. So, first of all, I think that your observation is spot on in that we are calling for more specificity so that patients truly understand what's going on with them when we make a diagnosis or when we're treating them, and also so the general public can understand exactly what we're talking about when we talk about these policy debates. Just as one example, I have had several patients that I've treated, and I know colleagues have had a similar experience for a miscarriage. So I think everybody probably knows what we're talking about when we talk about a miscarriage. But just to clarify, a miscarriage means that the embryo or the fetal human being has passed away spontaneously, not through any intervention. And technically the medical term for that right now is spontaneous abortion. And so that's a medical diagnosis that they go home with on their paperwork. And I've had several patients that called back into the office afterwards, very upset because they got home and they looked at their discharge paperwork and they saw that diagnosis on there. And there's been sort of a couple reactions that I've had when patients have called. One, somebody very upset that was even on their paperwork or in their chart anywhere, because they've said, well, I would never have an abortion, so why is that on there? Or two, someone genuinely confused and calling and saying, is that what happened? Did I have an abortion? And as a physician who cares so deeply about my patients and wants them to truly understand what's going on with them, also in the midst of such a tremendously difficult time as losing a child through miscarriage, I just think, I thought for a long time that we needed to change that terminology because it is very hurtful to patients. And so I think it's important that we use accurate language and that we start thinking as a medical community about terms that are very vague. In fact, even ACOG a few years ago put out a document about, there's sort of a variety of ways that we talk about types of miscarriage that actually don't have a lot of meaning. They're very vague. So I know we're going to get into that, but things like threatened abortion or missed abortion, things like that, that even ACOG a few years ago, before the Dobbs decision, before it didn't serve their political narrative, said, these are really non-descriptive terms. They're not really very specific. And we should change the way we're talking about this so that people know exactly what we're talking about. So, this sort of intentional confusion, I think, of saying that, oh, it's all the same thing. Abortion involves miscarriage care, it involves induced abortion, it involves all of these things, is in fact an intentional confusion, again, not only to serve a political narrative, but it also ends up harming our patients because it causes confusion and it causes, I think, hurt on top of a difficult situation for many women.
Yeah, this is a small divergence, but speaking of that, I recently did some content about the Society of Radiologists that came up with a lexicon where they were making recommendations to medical professionals who do ultrasound. And I fully expected them to recommend that they stay away from words like heartbeat or anything that uses the word heart. They want you to measure the beats of the cardiac organ that is not a heart. And I expected that, and it was an eye-rolling moment. But what I didn't expect was they went even further. And they had a section that said that they don't want ultrasound practitioners, I don't know how you would phrase it, to say living or alive in the first trimester. And they said in the document, they didn't say because technically it's not alive. They didn't try to make an argument that those words were incorrect or unclear to patients. They said that we should avoid them because people outside of medicine might appropriate those terms for political ends we don't like. In other words, if you acknowledge that the embryo is alive, that might be a problem for abortion rights. And so they're transparently prioritizing the politicization of this situation over their patients' understanding in their own pregnancies and their own circumstances. And speaking as someone who has gone to the prenatal appointment after already experiencing a loss, nervous and wondering if this time it's different, to prioritize you not wanting to say that the embryo is alive for political reasons over me needing to know if my baby is okay is it's insane. And I feel like ACOG is doing something similar here. So
Yeah.
one of the things I wanted to specifically hone in on is one of the phrases ACOG objects to is dismemberment ban. They say that it is, prejudicial, and they recommend instead saying dilation and evacuation. But then if you look up to date, if you look up the medical descriptions of dilation and evacuation, it talks about how this procedure often includes disarticulation, which I think is actually a very generous way of describing dismemberment. And I bring it up because, again, even if you have a patient who is seeking abortion and they want to know what's going to happen in their circumstance, how do we balance giving them information in an objective, low volatility way and making sure they're clear on what's going on? Do you have any thoughts on the best way to find that balance between, like you're saying, you don't want to say spontaneous abortion, you'd rather say miscarriage because that conveys what happened in a way that isn't so hurtful to them. I'm not saying we should be unclear to protect people's feelings. I'm saying we should be clear to make sure people understand what's going on. What are your thoughts on using technical jargon like dilation and evacuation, or intact dilation and extraction, when we know that the general public has no idea what that means?
Yeah. Well, I think it's important for people to understand that this is something, this sort of switch from medical language to language that people are going to understand, and language that clearly conveys, as you said, what's going to happen in a given surgery or with a given medication, something like that, is something doctors do all the time. So just as an example, when I'm currently work as an OB hospitalist, but I used to be in the office, sort of a traditional practice. And when I would talk to women about who were maybe considering a hysterectomy, I would say, okay, this is what a hysterectomy procedure is. But oftentimes, many women think, when they think hysterectomy, don't realize that hysterectomy actually only refers to removal of the uterus. Many women, I found many of my patients assumed that hysterectomy meant your uterus and your tubes and your ovaries and everything came out. It actually doesn't. Hysterectomy just means removal of the uterus. So while I might say hysterectomy, I would then go on to explain to my patient what that means. That means that we're going to take your uterus out. Doesn't necessarily mean we're going to take your ovaries out. If we, here's the reasons why we might do that. And if we do that, that's another procedure called an oophorectomy. But I'm not just going to go into my patient and say, we're going to do a hysterectomy and an oophorectomy. Would you like to do? I mean,
right.
That's not helpful to anyone, and I'm not meaning to make light of the subject that we're talking about, but I think it's important for people to understand that, I think ACOG and abortion advocates make it sound like this is the only time where we're trying to use different language and that we're doing it for some sort of gain for ourselves. No, it's because we want our patients to truly understand before they consent to a procedure, before they consent to a major surgery, before they consent to even getting a medication of some sort, they need to understand exactly what's going to happen. And so I think specifically in the case of a DNE, let's even use a DNC, for example. When I'm talking to a woman who maybe has had a miscarriage, who I'm going to do a DNC, I'm going to say dilation and curettage. Sure, that's what the procedure is called. That's what the surgery is called. But then I'm going to explain, here's what that involves. That involves going in and scraping out what's left inside of your uterus so that, you can continue to heal. So same thing with a DNE or dilation and evacuation. Sure, I should say that because that's what the surgery is actually called. But that means nothing to most people. And so it does need to be described what's going to happen. And whether you use the word dismemberment, the thing about using dismemberment is that's what people are going to understand. People aren't going to understand disarticulation. And to go into a room and say that to someone, I think just shows a complete lack of understanding of where most of your patients are going to be at.
Or a lack of interest.
Exactly. But let's think about disarticulation. What does that mean? It means literally pulling apart joints. So what is that doing? It's dismembering that baby. And so that's accurate. And a woman deserves to understand that that's what's going to happen during that procedure, during that surgery, before she consents to it. And so
this is particularly relevant in circumstances where parents might want to have remains for grieving processes.
Right.
I just want to speak up about that for a second because I never went through a procedure like that, but I had a loss earlier in pregnancy where my husband and I knew specifically that it was very important to us to be able to have the remains for cremation, for grieving processes. And it was like pulling teeth to get our medical team to help us make that happen, even earlier in pregnancy. I don't think this is a malicious thing. I think that there's just a chasm between medical professionals who've gotten very used to their protocols, their language, their framing, all people do that in their jobs, and their patients who they might have done, hundreds of DNCs for women who've had miscarriages, but this woman has never gone through this before. And it's hard, I think, sometimes for medical professionals to keep that level of almost that individualization, and this is another version of that, where you might very well think, I don't want to make this any harder than it needs to be for someone going through this. But for them, the patient, they need to know what's going to happen, and they need to know how they want to deal with it. That's pro-autonomy, is telling them what's going on.
Yeah.
So I appreciate that you said that. I think it makes sense to start with the correct terms and then define them in ways that your patients can understand. And true experts are actually very good at speaking at a very understandable language level. It's actually a whole art to take your very technical information and convey it clearly. It's not expertise to convey it at your technical level where no one knows what you're saying. That applies to lots of things, not just abortion. Yeah. Anyway, one of the things I really wanted to make sure we touched on is one of the first things in AAPLOG's glossary is to replace the word abortion with the phrase intentional feticide. Can you tell me more about why you put that in there?
Absolutely. So, the big, and I think we knew this was going on before the Dobbs decision happened, but certainly in the discussions since Dobbs, what we've seen is that I guess the vagueness of the term abortion is really kind of being exploited now and being used to cause confusion. Abortion actually it's about 100-year-old term in medicine. So it dates back to before we had ultrasound, before we knew why a pregnancy ended, if it ended spontaneously. And so technically, from a medical standpoint, abortion just means the ending of a pregnancy prior to 20 weeks for any reason. So it is actually very vague, and it is actually important not only for patients, but for physicians as we're communicating with one another, as you're reviewing someone's health history, to understand, why did that pregnancy end? If this patient sitting in front of me has had 3 losses in her first trimester, to me, okay, there's red flags there, that there's probably something going on, whether it be a clotting disorder or a genetic disorder or something like that. However, if those 3 pregnancies ended because they were induced abortions, what most people understand as elective abortions, that's very different. It's not ideological, it's medical. It's important to understand what's going on with a patient. And so that's why we are suggesting that we start moving away from the word abortion and moving into exactly what we're talking about. So was it a miscarriage? Was it a spontaneous loss, or an early pregnancy, a spontaneous early pregnancy loss? Or was it a procedure that intended the death of that embryonic or fetal human being? So, and we said intentional feticide because it gets a little clunky to differentiate intentional embryocide versus intentional feticide. But the idea is the same. Was this a procedure that was performed with the intent and in order to ensure the death of that preborn human being, that embryonic human being or fetal human being, either one? And so that's really important. And then you could further clarify that. So intentional feticide via what method? So intentional feticide via DNC, intentional feticide via DNE, via intracardiac injection, with a substance meant to stop the baby's heart. So that's actually very descriptive to me. If I'm looking at a patient's chart and I'm going through her history and I see that laid out, that's actually much more helpful for me as a physician who's maybe taking care of that woman later in her life or with her next pregnancy, than just seeing termination of pregnancy or abortion. And so, a lot of it was about definitely clarifying confusion that is out there right now as we have this discussion, but also really clarifying this is completely different from the situation of a miscarriage, and clarifying what the intent was. And I know we're going to get into later also then how that's differentiated from a procedure where we might have to end a pregnancy early, but our intent is not to end the life of that child.
Right. So it seems like AAPLOG is sort of working with 3 categories, and that is spontaneous losses that there's no intervention one way or the other, they happen, and that's the miscarriage category. And then there is what most people think of when they think of abortion, induced or elective abortion, which you are calling intentional feticide. And then the third category is what I think most people are calling now life-saving either procedures or life-saving medically indicated abortions kind of thing, and AAPLOG calls maternal fetal separation. And this is really important because there's a lot of confusion about what pro-life laws are intending, what kind of things we're trying to prevent versus not, and AAPLOG has spent copious amounts of time trying to clarify this. So can you talk a little bit about the difference? For example, I'm going to be very specific here. The difference between, say, you're inducing labor at 15 weeks because of previable rupture of membranes on the one hand, versus if someone induced labor at 15 weeks when there is no medical problem and the procedure is the same. How would you describe those two situations?
Yeah, absolutely. So I think this is a really important point to make, because many of the technical procedures that we use for treating pregnancy complications or miscarriage might be the same technical procedure that are used for elective induced abortions.
Right.
And so so it's important to point that out. It's important to point out that no law in the country prevents an actual procedure in and of itself. They prevent that procedure with the intent of ending the life of a preborn child if that state outlaws abortion. So intent is really 100% the difference here. So in the first situation that you described, where a woman's water breaks before a baby is viable outside of her, that does pose a threat to the life of the mother because of the threat of miscarriage, or I'm sorry, the threat of infection and hemorrhage, and a small but real risk of sepsis, especially if infection is left untreated. And so one of the options for management of that would be immediately intervening to separate mom and baby. So your goal in that is your intent is to prevent that risk to the mother's life. You don't have to do that in a way that guarantees or intends the death of that child. And that's very important. So there might be some people that would intervene in that situation, and they would do something that would ensure or intend the death of that preborn child. Most practicing OBs that I know will actually induce labor in that situation after discussion with the patient. There are some who would do a D&E procedure. But many OBs will induce labor because, as you said, many families in this situation actually desire to have an intact child that they can hold and they can grieve. I think it's also important to point out that we don't always have to intervene. Of course, after talking with mom and that shared decision making, some women will elect for expectant management, which ACOG says is a perfectly reasonable option for management if there's no signs of infection. But every state law in the country allows for you to intervene even immediately if that's what the patient desires, because of that potential risk to her life. So that's different. You have this potentially life-threatening situation for mom. Your point in intervening is to prevent that from becoming life-threatening to her. Your point in intervening is not to end the life of the child. Versus a mom at the same gestational age, say 15 weeks, like you said, where we intervene maybe with an induction of labor as well, but there's no other purpose for intervening other than she wants to end her pregnancy. So you are intending to deliver her with the intent that that child is then going to die, whether you induce that death before delivery or whether the child is just left to die after. So intent is very important. And I think one more thing to point out just really quickly is that this is not, the issue of abortion is not the only issue within medicine where intent matters. So if I recommend to my patient who's in labor that she have a C-section because my intent is to speed up her delivery because I've got dinner waiting at home, that's not an okay intervention. If I recommend a C-section to her because I see signs of distress and my intent is to actually ensure that her baby has a good outcome, then that's an okay intervention to recommend. And so while it might seem a little flippant to use that as an example, it's just, it is a real example of what we do in medicine.
That is not flippant. There's a whole lot of concern about how often C-sections happen in the United States and what the exact reasons are for those. I think that's a very relevant example.
Yeah.
And I think that it helps if you can take examples in obstetrics outside of abortion, just to show that this is a normal principle that we have to think about.
Yeah,
I appreciate that a lot. Yeah, that's a
absolutely.
great example. I think it gets a little tricky very quickly. One of the things we've talked about with secular pro-life, when we're talking about intent,
Hmm.
pro-choice people will say that the intent of abortion is not to kill anyone. It is to end a pregnancy, and it's not their fault if the pregnancy ends earlier than the child can survive. And if there was a way to end the pregnancy, say in our example at 15 weeks, without the child dying, then that would be fine, because that's not the purpose. And one of the ways I think we can kind of tease this out a little bit, I know this is very sci-fi, but we have now at Secular Pro-Life collected several different publications from abortion advocates talking about the concept of artificial wombs. What if there was an artificial womb? What if you could transfer a 15-week baby into an artificial womb instead of the abortion procedure? And generally speaking, abortion advocates at the academic level have viewed this as a threat to abortion rights, not a way to resolve the issue peacefully. And they'll talk about not just the right to not have your body used against your will, but also the right to avoid genetic parenthood. And I think that
Hmm.
really illustrates, if you're trying to tease out, I'm not saying that applies to every single woman who's ever gone in for an abortion. I'm
Sure.
sure on an individual level, the motivations are variable. But in terms of the broader overall, what are we doing here? If it was really just about refusing use of your body, artificial wombs would be a solution, not a threat.
Right. Right.
And anyway,
Absolutely.
it's just something
Yeah.
that I found interesting and horrifying.
Yeah.
Um, Very quickly, I know we only have so much time, but at one point, AAPLOG said that they recommend against saying healthcare provider and instead saying healthcare professional, which I had not thought about at all. Can you talk more about why you want to make that switch?
Yes, and thank you for asking me about that because it's one of my soapbox issues, I feel like.
Oh,
But um, there has been a shift in how medicine is viewed and how medical professionals are viewed, as we've shifted more towards focusing on patient autonomy, which is a great thing. You know, if you look back decades ago, it was the doctor came in, just told you how it was going to be, and that's what happened, and you didn't have a say in it. I'm not saying we should go back to that, but unfortunately, as is often the case, the pendulum has swung so far the other way to where we are now have now elevated patient autonomy in many cases above everything else, above every other sort of tenet of medical ethics. And it should play a very important role, but it shouldn't trump everything else. And so what has happened as we've moved towards this like complete autonomy of patients is we've moved into a provider model of care. And that provider model is I am just here to be a provider of whatever it is that you ask of me as my patient.
regardless of how medically indicated it may be.
Exactly, exactly. So, whatever I ask for, and I think people can probably think of many instances in medicine that this has impacted. You know, there are several issues, I think, through medicine where good medical expertise and judgment has been set aside because, well, this is what my patient is asking for, so this is what I'm going to give. I think a really crude way of putting it, but it's one I've heard many of my colleagues reference is it's kind of like I'm an ATM. You put in your card, you put in what you want, and I spit out the cash to you without any sort of, you know, use of my medical expertise, of all the training that I've had, of, you know, thinking, well, I know that right now this seems like it might be a really good idea, but let's think about the repercussions that that could have and talk about that.
Yeah.
And so we've really moved to this provider model. And so
It's kind of
what
a
we
commercial
yeah,
mentality, really.
yeah, totally.
I'm sorry to cut you off. I just wanted to say that I know for a lot of medical professionals, not even related to obstetrics, there's so much pressure to make sure that you are financially solvent at a given hospital, and they have patient reviews and patient surveys. And if patients aren't satisfied, even if the satisfaction is based on you giving them whatever medication they want, whatever intervention they want, it can be a lot of pressure for you professionally, even if it's not related to whether or not you're taking care of them in terms of their medical needs.
Yeah, absolutely. I mean, it's just become very transactional,
Yeah.
as opposed to this is a vocation, this is a profession, and we should treat it as such. And I think we actually treat our patients better when we view it as such, because then it's not this transactional relationship; it's a fiduciary relationship that I have a direct responsibility for you as my patient to give you accurate information and to take good care of you. And that involves utilizing my medical expertise. And so that's why we really have pushed back. Sometimes we even find ourselves slipping into it because there's so many people other than physicians that provide medical care for patients right now. But so that's why we like the term either healthcare professional or medical professional if we're talking about someone other than a physician, but not using the word provider.
Does clinician apply to different kinds of medical professionals, or is that meant to be only physicians?
No, that could apply in other cases as well. Yeah. And so it's really that I'll actually make a plug. This doesn't benefit me in any way. I'm not getting a kickback from the authors, but Far Curlin and Chris Tollefson wrote a book called The Way of Medicine, and they're actually going to be keynote speakers at our upcoming conference in February. But it's really good. And it actually talks about this development of the provider model of care and how it's detrimental to not only the profession of medicine, but to patients as well. So if anyone wants to learn more about that, I would really encourage you to read that book.
Say the title again.
It's called The Way of Medicine.
Okay.
Yeah, very good book. So
and
come to our conference. This is a good plug for the conference because they're going to be our opening keynote speakers.
And it's in Florida, right?
It's in Florida. Who doesn't want to come to that? That's right.
February in Florida. That seems like a good trade.
That's right. Absolutely. Yeah. Absolutely.
All right. Well, I had 18 more questions, but we'll have to schedule another one.
That's right. That's right. I think this is a really important topic to cover. So I would love to do another one on this as we continue to sort of pick apart and really look at, are we giving our patients accurate information, or are we talking to them in a way that maybe serves a political narrative, which really, physicians should be above that fray, right? We should be about providing the best care to our patients and ensuring that they have accurate information about that care, not using politically charged language, which is really what AAPLOG is striving to do. So Monica, thank you so much. I enjoy these conversations, and I feel like we always are saying we have to do another one because they're just really great conversations.
Sure.
Tell our listeners, how can they find you and Secular Pro-Life so that they can follow your content? Because as I said, I read it all the time. It's great.
Thank you. Secularprolife.org is the website. We are also on all the major social media channels. Usually it's a single word, Secular Pro-Life. I regret to say it's not literally always, but on Twitter X, on TikTok, on Instagram, on Facebook, all of those things. I want to also say very quickly, it's not just me. I'm often the face of the content, but you said earlier, how do they get it out so quickly? I have a team that helps me do that helps with video editing, that helps with writing things up, that helps with finding citations. And they work very hard to try to respond to a lot of different topics, especially right now coming up. And how do we talk about this? How do we think about this? What makes sense? So if you're interested in fact checking, if you're interested in trying to be objective and trying to find common ground with the other side and trying to find a way to have these conversations usefully, secularprolife.org. You should check it out.
Amazing. Thank you, Monica. I think it's so important that you guys exist too, because you blow apart the false narrative that being pro-life is a religious position. And, you guys help us show that it's actually rooted in science and logic and a belief in the equal value and worth of all human beings. And that's why we're pro-life. And so I just really appreciate what you all do. And thank you to our listeners and our watchers for joining us today. If you like this episode, be sure to give us a like and a subscribe on YouTube, or if you're listening on a podcast app, give us a 5-star review. I also just want to take this opportunity to say thank you so much to our dues paying members and to our faithful donors. You all are the ones that are enabling us to continue to clarify in the midst of confusion that's going on right now, and to speak the truth and speak accurate information. We can only continue to do this with your dues and your support. Many of you know AAPLOG launched an advocacy arm called AAPLOG Action this year, and we are striving to support physician voices in states throughout the country. So we just so appreciate your support, and would encourage you to continue to support or let friends of yours know if they're interested in supporting our efforts. Thank you so much, and we'll see you on our next episode.